Welcome back to the MediByte channel. I'm your host, and as a healthcare professional, I am honestly so thrilled you're joining us today. In this explainer, our goal is to calmly and clearly walk through the clinical protocols for unexpected childbirth complications. We're going to focus heavily on a topic that sounds incredibly intimidating but is actually deeply understood by modern medicine, and that's fetal distress. So let's just dive right into this and see exactly how medical teams keep both mother and baby safe.
Here is our clinical roadmap for today's explainer. We'll start with 1. Understanding fetal distress. Then 2. Causes and heart rate monitoring. 3. First-line medical interventions. 4. Emergency delivery methods. And finally, 5. Rare complication, uterine inversion. Knowing what to expect really helps take the anxiety out of the equation, so let's follow this plan.
All right, Section 1. Understanding fetal distress, defining the emergency.
So, what exactly is fetal distress? Basically, it refers to signs that show up either right before or during childbirth, indicating that the fetus just isn't doing so well. And it almost always boils down to one crucial thing. The baby is not getting quite enough oxygen during the labor process. You know, the uterus is a massively powerful muscle, and labor is a wildly intense physical event, which can sometimes temporarily disrupt that vital flow of oxygen.
But I really want to stop right here and establish right off the bat that fetal distress is an absolutely uncommon complication of labor. The term distress understandably sparks a lot of panic for expecting parents, for sure. But from a medical standpoint, it's so important to remember that the vast majority of labors progress without this happening at all. And when it does happen, well, care teams are specifically and extensively trained to handle it.
Let's move to Section 2. Causes and heart rate monitoring. Why it happens and how we see it.
So why does it happen? Well, there are 3 main clinical triggers. First up, we have post-maturity. This simply means the pregnancy lasts too long, going well past that standard due date. When this happens, the placenta might just not function as efficiently as it did earlier on. Second, we see it in especially difficult or exceptionally rapid labor. And third, a really common trigger is contractions that are just too strong or too close together. If the uterus contracts violently without giving the body enough rest in between, it literally squeezes the blood vessels, momentarily limiting the oxygen reaching the fetus.
And this brings us to how we actually detect it. This quote is pretty much the golden rule of obstetrics. An abnormal heart rate in a fetus may be the earliest sign of fetal distress. Actually, before the mom feels anything out of the ordinary at all, and before any other physical signs manifest, the baby's heart rate is going to fluctuate. It acts as the ultimate early warning system, which is exactly why monitoring it is the absolute highest priority in the delivery room.
So let's look at how we listen to that early warning system. There are really 2 primary methods. First, we have continuous electronic monitoring. This is where sensors are placed right on the mother's abdomen to track the baby's heart rate constantly throughout the entire labor. The other method is the handheld Doppler ultrasound approach. With a Doppler, a nurse or doctor will manually check the heart rate every 15 minutes during early labor, and then immediately after each contraction once late labor hits. Both of these methods ensure that if the heart rate drops or spikes abnormally, the medical team knows instantly. Okay, Section 3, first-line medical interventions, quick, non-invasive fixes. The very second a significant abnormality in the heart rate is detected, the medical team doesn't just jump straight to surgery. Instead, they rapidly deploy 3 super simple, non-invasive steps. Step 1, they give the mother oxygen. By increasing the oxygen in her blood, more of it is directly delivered to the baby. Step 2, they increase intravenous or IV fluids to give a quick boost to the blood volume. And Step 3, they turn the mother on one side or the other. This simple repositioning takes the physical weight of the uterus right off the major blood vessels in her abdomen, which can instantly restore better blood flow to the placenta. At that exact same time, the team is going to aggressively manage the mother's contractions. If a drug like oxytocin was being used to medically induce or stimulate contractions, they stop it immediately. The mother is repositioned, and she might be given analgesics for pain. But what if her body is just naturally contracting too hard? Well, in that case, the care team might inject a drug called terbutaline. Terbutaline effectively slows down or even entirely stops the contractions, which gives the baby's oxygen levels a crucial, much-needed window to recover.
Which brings us to Section 4, emergency delivery methods, when swift delivery is necessary.
Now, if the baby's heart rate doesn't stabilize after giving oxygen, pumping fluids, and managing those contractions, the objective shifts. It becomes all about delivering the baby as quickly and safely as humanly possible. Obstetricians rely on 3 primary methods here. The first is a vacuum extractor, which applies gentle suction to the baby's head to guide it through the birth canal. The second is the use of forceps. These are specialized instruments used to very carefully assist the baby's head out. And third, if a vaginal delivery just isn't safely progressing, they will move to a C-section delivery, or C-section. These are highly practiced, routine operative protocols that doctors are incredibly well prepared to perform at a moment's notice.
Let's move on to Section 5, Rare Complication, Uterine Inversion, a Post-Delivery Emergency. Even after the baby is safely delivered, the care team stays completely vigilant for a very rare but totally critical postpartum complication called uterine inversion. This is a medical emergency where the uterus literally turns inside out, protruding right through the cervix and sometimes going into or completely through the vagina. It sounds shocking, right? But how does it even happen? Well, typically, it occurs during the delivery of the placenta. If the placenta is firmly attached to the uterine wall and doctors happen to pull too hard to remove it, the uterus can invert. And this is highly critical, mostly because it can lead to severe, life-threatening blood loss for the mother. But here is the reassuring part. Just like with fetal distress, the medical response to a uterine inversion is structured, incredibly fast, and highly effective. First and foremost, doctors will manually push the uterus back up into its normal position. Because, obviously this is painful, the mother is given pain relievers, sedatives, or sometimes even a general anesthetic. And remember terbutaline? That same drug we used to stop contractions earlier is often given intravenously here to relax the uterine muscle, making it a whole lot easier to push back into place. Simultaneously, IV fluids or blood transfusions are administered to replace any blood she lost. Occasionally surgery is required, sure, but with prompt treatment, the vast majority of women recover fully from this.
So, that's the whole picture. Knowing how unbelievably structured and advanced obstetric medicine is today, how does understanding these exact protocols change your perspective on labor emergencies? Medical terms can sound really scary, but seeing the clear, step-by-step science behind how healthcare professionals actually manage them should give us all a profound sense of reassurance. Thank you so much for learning with me in today's Explainer. If you appreciated this clear, structured look into medical protocols, please do not forget to like, share, and subscribe to the MediByte channel for more deep dives into healthcare. Until next time, stay curious and stay well.